Happy to welcome you from Partners Against Mortality and Epilepsy, or PAME. My name is Ann Gramiak, and I'm the Senior Manager of the ELC and Partnerships at the American Epilepsy Society, and I'm a member of the PAME Governance Committee. For those of you who may be new to PAME, our mission is to convene, educate, and inspire all stakeholders, from the bereaved to those living with epilepsy, to healthcare professionals, advocates, clinical and basic scientists, and death investigators, to promote understanding, drive prevention of epilepsy-related mortality. Before we get started today, I'd like to recognize the organizations that supported our 2002 conference and this 2003 webinar series. I would also like to thank all of you for joining today. I do want to share a few housekeeping tips, and those include using our question and answer feature in Zoom to submit your questions. That will help our moderator when the time comes at the end of the presentation. We also encourage use of the chat to connect with other attendees. We're going to be recording today's webinar, and that will be posted on PAME's website at the end of the day, and you will receive an email once it's available. So now I'd like to introduce Tom Stanton from the Danny Did Foundation, who's going to be today's webinar speaker.
Thanks, Ann. I'm Tom Stanton from the Danny Did Foundation, and Danny Did is a partner member to the PAME effort, and I'm happy to moderate a fantastic panel today on a very important and exciting new resource that we're here to tell you about. And just a quick background about me. I came into this community about 13 years ago after my nephew Danny passed away from SUDEP at the age of 4. So very excited to be able to try to move the conversations around epilepsy mortality ahead. And this resource we're going to tell you about is a big piece of that. So I want to introduce our three speakers. Cyndi Wright is the program manager at the Child Neurology Foundation, and she was instrumental in coordinating the people and organizations who contributed to this toolkit resource. Dr. Dan Freedman is an assistant professor of neurology at the Dell Medical School and a pediatric neurologist and epileptologist in Austin, Texas. And our third panelist is Dr. Shawna Benard, who is an assistant professor of clinical neurology at the University of Southern California and medical director of the Keck Hospital Epilepsy Monitoring Unit. So we welcome all of our speakers here today, and just to remind Ann's prompt to use the Q&A box if you have questions, and please keep them to the scope of this webinar, and then we will address as many as we can during the Q&A segment at the end. So with that, I will turn it over to Cyndi.
Thank you, Tom, and thank you to PAME for helping us promote this toolkit. It's been a long time coming, and I'm really excited about it and excited to help share it with everyone here today. Let's see. Oh, there they go. So the goal of this group was to drive measurable behavior change in medical providers and people with epilepsy by increasing the awareness of SUDEP and epilepsy mortality and what could be done to decrease the risk. So when we started this project, that was our big goal, and we had to figure out how to get there. So the Epilepsy Foundation hosted a SUDEP summit. I guess now it's been about 3 years since that happened, 2.5 years. And that is where they came up with some different groups to do things to drive SUDEP initiatives. So we took on, the Child Neurology Foundation agreed to take the lead on the behavior change and awareness initiative. And in that, we brought together a project advisory committee that included CNF, AES, Danny Did, and the Epilepsy Foundation, and we were supported by the BAN Foundation. And initially, we did a landscape assessment of what's out there now, what's working both in the epilepsy space, but also in other disease states. And then we also, if we're trying to drive behavior change, what is behavior science? So we took a lot of time learning about behavior science models and theories, and that helped us develop the intervention plan, which is this toolkit. We were really excited because when we started this, we had amazing support from so many experts who've been in the space a long time and others who are new to the space. We had people with epilepsy, caregivers of people with epilepsy, family, siblings of people with epilepsy, as well as the scientific community, the clinician community, and the advocacy community. So those are all their names. And then the partner organizations, again, I've been in the epilepsy space a long time, and we can't always get everyone engaged, but we engage not just the epilepsy space, but the American Academy of Neurology, the American Academy of Pediatrics, the American Association of Neuroscience Nurses. So we really had a broad group of people coming together to support, and these organizations also stand behind the toolkit itself. Oops, one too many. So how is this different than what's out there? One, we use this behavior science approach to raise awareness, because what we found is just we don't know that telling someone about SUDEP is going to change behavior. And by learning behavior science, we learned what changes behavior isn't telling someone necessarily to do something, it's addressing the barriers to do it. Anyone with epilepsy wants to do their best to manage their epilepsy. So what's getting in the way of that? And then clinicians have always told us, we don't have time, we don't know what to say, we don't know how to say it, we're afraid we're gonna, make people feel uncomfortable. So we needed to make sure we address those issues. And so we created this toolkit that's easy to use and hopefully will be used by clinicians and families. And then we are going to test our approaches in an actual clinic setting to see how much change they actually drive. So that is not yet done, but it is in the works or in the planning stage. So we tried to make this simple, but basically one of the gaps right now is not all people with epilepsy are getting assessed for their risk of mortality. So we feel that's really important, not just for SUDEP, but for all risks of mortality. Some people are more at risk than others, and there are some risk factors that Dan will get into that a lot of clinicians may not think about. The second step is to actually act for those, act on those behaviors. A lot of doctors have said, I'm not going to scare my patient with this information because there's nothing can do about it. But there are things people can do about it. And so we wanted to make sure clinicians knew what those things were. No, we don't know exactly what causes SUDEP or some of these other causes of death, but there are things to do to decrease the risk. And then the most important part, I think, is this empower part, empowering families to make this change and so they can take better care of themselves and reduce their risk. And Shawna is going to tell you more about that. So with that, I will turn it over to Dan.
Awesome. Thank you, Cyndi. You're a hard act to follow. I like to say that she's the Leslie Knope of our group, and just this would not have happened without her, without CNF, Tom, all the people from AES. So it's been a really, truly multidisciplinary approach to this, which I think is one of the reasons why it's going to be really effective. And so we wanted to look at all the risk factors to include in this tool. We started with 96 different risk factors. And I mean, there's a really, really long list of every possible thing that we could think of that might impact epilepsy mortality, right? And to Cyndi's point about the doctors saying they're too busy to do some of these things, to patients not knowing about some of these things, we had to balance what can we meaningfully share with people that we can actually act on and change compared to every possible thing that's out there. So we started with this list of 96. We pared it down to 9 things in 4 categories. The way that we did that is we used this system where we looked at things that we have kind of the highest confidence that we can assess it in a clinical setting, like in your visit to the neurologist, and then also how can you have good confidence that we can make some sort of measurable change for that risk factor to help that patient. And so we had to balance those things until where we both end up in that kind of green box there. And that's what led to a lot of these shifting things. So there are lots of good ideas that we had about, different mental health assessments, but the reality is we're really bad at assessing, someone's general anxiety level in a 20-minute doctor visit. So even with the screening questionnaires and stuff that we use, so that category is a little bit harder to assess for, or something like emergency medical services utilization is something that we could assess for a little more easily. And so we try to focus on the things that we had the most ability to assess for and ability to modify, which is important. There's the list popping up on the side there. So you can see all the things that we had to kind of bump down the list and deprioritize a bit, but still with a very robust list of 9 risk factors. So we looked at all patients with epilepsy, of course, that's why we're here. But within that, we wanted to look at high-risk seizures, accidents related to seizures, and unsupervised seizures as 3 of the most high-risk categories for mortality. And we put that under the kind of umbrella category of seizures and syndromes associated with increased risk of mortality. Then we wanted to look at health services. So we know that having access to comprehensive epilepsy services is important. So that's being referred to a center where they can offer things like, genetic testing, ketogenic diet, surgical services, things like that. And then also having frequent use of emergency services, as I alluded to, is another thing that, if you're in the ER a lot for breakthrough seizures, mental health services, things like that, that's going to increase your risk of mortality as well. And then that kind of also segues into the next category of comorbidities. So having high risk medical comorbidities like respiratory issues, having a trach, having a G-tube, things like that. Having mental health issues is another important risk factor. And then I think a really big one that as a medical profession, we could do a lot better job addressing is social determinants of health. And so the medication management and adherence, and this is things like one of my pet peeves that I always try to impart to residents and trainees and stuff is you can't prescribe one medicine 3 times a day, another medicine 2 times a day. We make things really difficult on families, or we start medications with really high side effects, and then people don't want to take their medication because of those side effects. And so we have to be careful in how we can facilitate adherence as much as possible. And then, of course, there's the actual social piece of that of poor insurance coverage, prior authorizations, peer-to-peer denials, things like that, where patients physically cannot even get the medication that we're recommending. And so making sure we have access to social work and other things to help facilitate patients getting insurance, getting the medications they need, financial assistance programs, things like that. So these are all the 9 risk factors across our 4 categories. And then the kind of process behind all that was a lot of meetings. So it looks very distilled down in this, but within each of these is a bit more detail on how we're going to address these. And so as you can imagine, if you have 10 neurologists in the room, you're going to get 11 opinions. And so we had a lot of opinions on what else we should include, what else we need to change. I was very grateful for the fact that we had lots of non-neurologists in the room too. So we had lots of people that brought outside perspective from an epidemiology standpoint, from a social work standpoint, from a patient advocate standpoint. So there's a lot more to this than we can see right here on this page. And I think that's important to take into account as well. So for step 2, we wanted to act on those things that we can identify. This is a really broad overview of what any clinician can and should do in when seeing an epilepsy patient. I think where this gets also tricky is that, realistically, we can't do this at every single one of these things at every single visit. And so I think the way that we approach this is to say these are things that we should think about. They don't need to necessarily be actively addressed every single time, but to think about does my patient need lab work? Are we having medication side effects? What's the next step in evaluation? More EEG, genetic testing? Do they need to be referred to a epilepsy center that can offer, specialized diet or something like that? So there are lots of, basically this list is to encourage that thought process and encourage thinking about, does the seizure action plan need to be updated because now we're having more frequent seizures, or that dose of rescue medicine didn't work? Do we need to increase the dose? In my world, it's a pretty frequent thing that, as kids grow, we have to adjust their medications. So we're often checking the seizure action plan and updating rescue medications when appropriate. But just having that reminder in the clinician's mind to say, this is something we need to think about. And then we have slightly more detailed versions of this on the website where, so for each one, you can say, let's think about the different seizure types this patient has. So there's more detail for the clinician about what are the things that actually drive increased mortality risk. What can the patient do to help modify that mortality risk? And so talking about, using a seizure diary to keep track of seizures and when we're having, are they nocturnal seizures? Are they unsupervised? How many GTCs in a year are we having? So the generalized tonic-clonic seizures, we know that can also increase mortality. And so making sure that we, think very holistically and comprehensively about what's going on with that patient in regards to their seizure burden, the medication burden that we're on as well, and making sure that we address any concerns that come up in that visit. And then whatever we can address in that visit, making sure that if we didn't do that visit, the next visit, we're going to talk about some of the things that we didn't get around to in that visit. And so these information sheets for the clinician, I think, are really helpful tools to encourage that assessment of things that we should always be thinking about, but sometimes it's hard to remember every single visit every time for all the different things we need to screen for. But if I haven't talked about, respiratory concerns or, sleep study for a patient that has nocturnal breathing issues, that's something that needs to come up at some point. Another one that I think often gets sidelined in our world is transitional care. So making sure we address patients going off from teenage years into adulthood, changing jobs, changing life, living arrangements. So those types of major transitions affect our patients' ability to care for themselves, for their loved ones to care for them. And so we need to be addressing those kind of social concerns as well. And I'll hand it off to Dr. Benard for the Empower step.
Thank you, Dan. So now, with all that information, how can we empower people with epilepsy as well as clinicians on this topic? I want to emphasize educating not only your patient, but also those that they spend the most time with, be that caregivers, parents, significant others. Also regularly reevaluating a patient's risk as they enter different phases in their life, since their risk level may change. And asking about barriers to care and providing solutions. Also, very important to provide appropriate resources, connecting with advocacy groups, as well as providing our handouts that we will talk about for the patient and their caregivers. To advance, there we go. Went one too far. So the Empowering Conversations Guide is a really useful tool. It provides helpful video scenarios and conversation starters to give examples of ways to communicate risk effectively and compassionately. It also reviews motivational interviewing techniques such as the OARS acronym, which stands for asking open-ended questions, affirming, reflective listening, and summarizing. It also discusses how to address barriers to behavior change and assess a patient's capability, motivation, and opportunity to change their behavior. This is known as the COMB or COMB behavior change model. And this can help really decrease provider discomfort and give them more confidence to discuss this topic. Really at any stage in their career, this can still be useful. So one example that's provided on the website of a way to introduce this topic to your patient would be to say, most patients with epilepsy live long, healthy lives, but there are risks associated with epilepsy, including injury and early death. My job as your provider is to give you information on ways to reduce these risks. Because of some epilepsy-related factors, such as type of seizures, uncontrolled seizures, you or your child, depending on who you're talking to, are at high or low risk, depending on their risk level of dying from epilepsy. And we can address this by. So some other examples that are provided on the website to start the conversation and address patient fears I wanted to review, I think are useful. One example would be, what have you heard so far about risks that can come along with epilepsy? This can be hard to talk about. There are serious risks that come along with epilepsy. And do I have your permission to tell you a little bit about them today? I know having or witnessing seizures can be very scary. Some of my patients ask me if they or their child can die from epilepsy. Unfortunately, the answer is yes. People with epilepsy have an increased risk for early death. But the good news is there are things we can do to decrease the risk. And what have you heard about the serious risks associated with epilepsy? And then lastly, what is your greatest fear with epilepsy? Do you have any worries about dying from epilepsy? So I think these are nice examples because they are honest, but they do provide hope. They ask patient permission to discuss the topic, which I think is a really useful way to approach this conversation. And they also ask the patient first about what they have heard and their specific fears. So you kind of get a baseline context of their knowledge on the topic, or if they have had any education about this before. Then shown here on the right side of the slide is an example of suggested communication when your patient has medication management and adherence complications, as an example. And it shows a kind of simulated conversation between a provider and a patient. Demonstrates using open-ended questions and really trying to understand what the patient's specific barriers are. And this can really help provide tangible solutions. And then there are several other different conversation topics that you can look at, such as if your patient has mental health considerations, and if your patient has social determinants of health considerations, essentially most of the topics that we have previously discussed. So this is a checklist here that is available for patients to utilize. Here are listed factors that can increase the risk for death and how to decrease those risks. These include reducing the number of seizures a patient has overall, creating a seizure action plan, minimizing the risk for accidental injury, providing supervision as appropriate, considering a seizure detection device, and updating your doctor about any health or medication changes. So this is a useful tool that kind of can organize a patient's thought process in approaching these conversations. And then here pictured is the first page of a 3-page handout that can be downloaded from the website and to be filled out by the patient before their neurology visit. It should be brought to the visit to aid in focusing on specific information that can help the provider understand that patient's risk for death. It asks for such information as seizure type, frequency, duration of seizure, the times of day that seizures occur, any issues with medication adherence and side effects. It asks about high-risk medical comorbidities, specifically things like cardiac and lung disease, kidney disease, and then also high-risk activities that they may engage in terms of things that they do at work or in leisure time, or just daily activities that they participate that might increase their risk of injury or death. Any recent significant life changes or life transitions, as well as some mental health questions. So here is a handout for clinicians, which succinctly summarizes the 3 steps of assess, act, and empower, giving high yield guidance in each of those topics. Can go through this here, what we had spoken about before, summarizing and assess. You want to understand the seizures and syndromes that's associated with the increased risk of mortality, and acquire into patients' lifestyle and recreational activities, major life changes, and assessing their supervision, as well as high-risk medical comorbidities. And it mentions some barriers to quality of care to take into consideration here. Any complications with medication management and adherence, access to comprehensive epilepsy services, and frequent use of emergency services. In the ACT section, a reminder to review all medications at each visit, and kind of be aware and up to date of any changes. And develop and review the treatment plan and treatment options. Order genetic testing if there's worsening of seizures or diagnostic uncertainty. And routinely evaluate any need for laboratory studies. Also, additional actions to consider if the patient's not responding to treatment, refer them to specialists as appropriate. If multiple clinical care providers see the patient, ideally creating mechanisms for coordination of care, and importantly, developing a seizure action plan that can be used either in the home or school or wherever the patient is residing or spending most of their time, and including rescue medications when appropriate. And lastly, what we just spoke about, empowering, so educating people with epilepsy and their caregivers, making sure they understand their seizure types and their risk factors for increased mortality, and explaining how these comorbid conditions can also have a significant impact. And regularly evaluating and explaining the individual's current risk factors for death and the actions they can take to reduce that risk. Additional actions you can take to empower people that we spoke about, asking about barriers to care and suggesting tangible solutions, providing resources to patients and their caregivers, as well as that great 3-page handout that, again, you can download from the website and is very useful for patients and their providers. So how can clinicians make the most of this toolkit? To learn the risk categories and the associated actions that medical providers can take to decrease the risk of death, learn how to have these empowering conversations on this topic, utilizing this website really to make yourself comfortable with how to initiate these conversations, I think is a really great benefit of what's provided here. Ask your patients to complete the handout before their visit so you can really narrow down into those high risk factors that need to be addressed. And follow the recommended actions to decrease risk, and share the handout with other clinicians as well. And how can people with epilepsy and their caregivers make the most of this toolkit? Learning the steps to take to decrease the risk of dying from epilepsy, completing that patient handout prior to seeing your neurologist, and scheduling an appointment with your neurologist, really with the goal in mind of talking about this topic. And, also having a sense of comfort and knowing how to initiate that conversation with your provider as well, and how to reduce your risk. And also to share this handout with other people that you may know with epilepsy as well as caregivers. Okay, and this is our website, preventingepilepsydeaths.org.
Great. Thank you, Dr. Benard and Dr. Freedman and Cyndi, for all this information. I know it's a lot. This is a very comprehensive resource, and we've gotten a few questions about accessibility and where to find it, and this website is the primary outlet for that. And when you get a chance to visit there, you'll see the navigation is broken out by the type of viewer, so clinician or caregivers, patients. So we encourage you to visit this website and utilize all these resources. We have gotten a good amount of questions, so I want to get right to that and start through some of these. And again, if you have other questions to add, please use the Q&A box to submit them. So I'll kick this one off, I think maybe to Cyndi. The question is, has a person or multiple people with epilepsy been consulted on this communication toolkit? And I know you can speak to that and have a little bit already.
Yeah, so we absolutely had people with epilepsy. We made sure that was a really important component to developing this, because if it's all the doctor's perspective, how useful will it be? So we had the people with epilepsy, we had caregivers, as well as advocacy organizations, and we encouraged them through this process. It was a 2-year-long process to reach out to their community and get their feedback as well. So it was a very open, collecting feedback in both directions. There's lots of modifications made as a result, which we kept making the toolkit better. So, and we still are taking recommendations. So as you go to the website and look at it, you can put comments at the bottom, or there's a contact us page, and you can send those, and we'll get everyone's perspective again and see if there's changes that need to be made.
Great. And then somewhat related, some of these will just be, kind of refreshing on some of the information shared, but I think it's good to emphasize these points that we're getting questions on. Who is the toolkit directed to? Is it doctors, patients, caregivers? I'll take a crack at saying I think it's primarily directed at clinicians, but also with resources for caregivers and patients. Cyndi or others, do you want to add to that?
I can go, and Shawna and Dan can add. So when we created the toolkit, it's a toolkit for clinicians, but in order for clinicians to be really effective, they also sometimes need a handout, right? Because they can tell you a lot of things during a visit and it's super overwhelming and you don't remember. So having these handouts to give to families are really helpful. And these visits in your clinic, they go both ways. So if you come in prepared to say, hey, I filled out this form, can you look it over and let me know if I have any risk factors that I need to worry about and what I can do about it? And also for the clinician, that's empowering. That saves them time, because it's a lot of information. It's a lot of questions to ask. So going into that prepared with specific questions and them knowing what's going on with your current health situation can really help make those conversations more effective.
I could also add that I think it's important that the toolkit's for everybody, but I think the largest population that it could reach really, or the population that we want to affect the most change in, is probably clinicians, because we know, there's really good data that clinicians are a bit hesitant to have this conversation because it's a scary conversation. We have lots of hard conversations in neurology all the time when patients have strokes and things like that. So we're not necessarily averse to hard conversations, but this is one of the tougher ones because in the same moment you're trying to tell somebody you have a new diagnosis of epilepsy, we want you to be able to do things like you did before this diagnosis of epilepsy. Our goal is for you to drive or to work or whatever, but then at the same time, you're trying to reassure them, but then you're trying to inform them of this without, scaring them to the point of, really giving them more anxiety about it. And so the thing that really changed my mind about this after, I'd say, several years in training of being very scared of this conversation personally, is learning that this is what parents and caregivers want to know and patients want to know. So we've got lots of data to back this up to say that this is a problem that we don't address nearly enough. We don't talk about SUDEP, we don't talk about mortality, and people would rather know that up front and what they can do to make a difference for that. And so giving clinicians that data and that information to say this is what people want, I think does matter.
Okay. All right, I'm gonna jump ahead to kind of two related questions, so I'll put them out there together. The first is the comment, my doctor has never talked to us about epilepsy mortality. Should we tell her about this website? And then the second that I'll pair with that is, what is the best approach to talk with my doctor about this resource? So anybody want to give advice on how to bring this forward to the provider?
Sure. So I think you can start by saying that you attended this webinar and, that gave you a lot of insight and information on this topic, and that it really encouraged you to speak with your neurologist about it. I think that's a good bridge into the conversation. And, you can certainly even utilize the tools and encourage you to do so and bring in the handout and, encourage them to speak with their colleagues about it as well.
Okay. I guess maybe tagging on to that last comment from Dr. Benard, we have another question that says, if doctors want any of the materials in hard copy, is that possible? Is the way to go to download and print, Cyndi, or what do we recommend as far as that goes?
Yeah, so all the handouts are available in as PDFs that you can download and print. And the more people we reach, the better. So print away. You can email links directly to it if printing isn't the best option. But yeah, we definitely want to get this out. And I know this question comes up a lot. So are we going to have Spanish versions? And the answer is yes, we hope to. That's just in another phase of the toolkit.
Okay, that's good news. Okay, so this one, a little bit nuanced. The question is, the risks of non-convulsive status epilepticus is under kind of discussed at most hospitals, even those that specialize in neurology. Can you highlight resources in this toolkit that go beyond the risk of SUDEP? Fair to say that this is kind of all meant in more general terms and not specific only to SUDEP?
I think that's one of the things I really liked about this project is we, it's going to raise awareness about SUDEP. It's going to, that's a focus of this for sure. But there's also all these other risk categories that impact mortality as well. One of the things I've always been passionate about is accidents related to epilepsy. So people that, whether it's drowning or being, or, even just, having fractures and things like that. So we know that there's a lot more risk of accidental injury with epilepsy, and that can be significantly increased for children and adults. And so being able to address that in a comprehensive manner, and that's just one small piece of this puzzle, right? And so then we also have the, other risk factors, the seizures themselves, the access to resources, all that kind of stuff. So there's a lot of different pieces of this that do go a long way to addressing that SUDEP risk for sure.
Okay. Okay. Question just came in. Could there be specific training, perhaps a video for clinicians to learn how to delicately broach this topic of SUDEP with caregivers? That is one of the great aspects, I think, of this resource, this toolkit. Dr. Benard touched on this a little bit, but we have multiple videos. Is that correct? I think maybe 4 different scenarios that we put forth.
I can take that one. So there's 5 different videos. 2 of them are really the family perspective, and that is really for the clinicians because we know the family stories are what drive them. But during those conversations, during those videos, there's also a clinician who speaks to why it's important and how she does it. The other 3 videos are examples of how to have the conversations, how to address the barriers, how to have these open-ended questions, how to summarize. So there are videos there. We'd love to create more. And I think, over time that will happen.
Okay, thank you, Cyndi. Okay, another question asks, can someone develop comorbidities after having seizures during childhood that extend into adulthood? Maybe speaking a bit to the vulnerabilities during the transitions of care and the different chapters of the transitioning. Dan or Dr. Freedman, would you have a comment on that?
Yeah, it's a good question. I think that certainly comorbidities can develop. It's kind of a correlation versus causation thing. We don't know exactly how they're related, but we do know a lot of people with epilepsy are going to have things like, maybe some difficulty with learning or difficulty with behavioral disorders, anxiety, and things like that. And so those are things that we routinely talk about in follow-up visits and stuff we try to screen for as best we can. And I think, giving that anticipatory guidance that these are things that could develop, even years down the road is an important thing for parents and caregivers and patients to be on the lookout for.
Okay, great. Okay, we have a question from overseas. I am a nutritionist by profession living in Kenya. And would love to understand the role of diet in epilepsy management, especially for clients on medications. Maybe speaking a little bit to the diet side of the equation and how that factors into the toolkit.
Sure, probably in a couple different ways. So, we talk about how important nutrition is for overall health. And how that benefits somebody. And then in terms of treatment for epilepsy, ketogenic diet or modified Atkins diet are often recommended, probably more frequently in pediatric epilepsy, but I think it's becoming more popular also as a treatment option in adult epilepsy when it's appropriate. And that is just another tool that we have to try to help control seizures and ultimately to try to decrease epilepsy mortality.
Okay, thank you, Dr. Benard. I'm going to keep going because we still have questions rolling in. So the next one, do adults need seizure action plans or are they only for children?
I'll let Dr. Benard weigh in, but first I just want to say that, I do see some adult patients because, like I said, we're not great at transitioning patients sometimes to adult care. And so I think everybody deserves a seizure action plan. And the question is, does everybody need a rescue medication? And that's my bias, I guess, but I'll let Dr. Benard answer.
Yeah, I would agree. It's in an ideal situation, everybody would have a seizure action plan. I think in some scenarios, it's even more useful, particularly people who are in school or in facilities or day programs, where there's a transition of care and maybe their usual caregivers are not there. So making sure that the people that are with them, during the day versus during the night, have, similar comfort level in terms of how to control and treat their seizures.
And I just want to add that, for adults, maybe who don't have seizures very often, that are in the workplace, that's important too, to let your colleagues know or HR department know, because, and I know a lot of people feel uncomfortable bringing it up, but they can do a seizure response training program and not say who needs it, but also, people want to be able to help you. And if you have a seizure and they don't know how to help you, that is more upsetting than finding out that you have epilepsy. So I know it can be hard, but it's also important.
Okay. Another question kind of related to that transitions period that we spoke about just previously. And I think I'll start with Dr. Freedman for this. Is there advice for addressing SUDEP when a person transitions from pediatric to adult care, which kind of makes me think about not only having the conversation, but kind of the frequency or the revisiting of the topic? Any thoughts or areas to point to in the toolkit for this type of question?
Yeah, we do address to some extent. It is a very difficult topic, right? In the sense that I don't know that anybody has the right answer to this yet. It's something that we talk about all the time at like AES, and so our annual meetings are devoting more and more time to how do we address transitions of care, because we need a better system where we can, I can hand off one of my patients to Dr. Benard, for example, and so that pediatric to adult transition is hard right now. And also we hear from parents all the time, we don't want to leave the children's hospital, right? Like, their child may be an adult, but they still are, that's where they've had their care their entire lives. And so it's a very challenging situation. But specifically for the addressing that SUDEP piece, so I think generally speaking for transition, we need to start early. So having that conversation in those like really early teenage years about, we know what's going to happen, when you become an adult, we know what's going to happen in terms of, for kids that are going to continue to live at home as adults, looking at guardianship, or if we're going off to college, looking at, not being supervised and away from their families. So there's lots of factors there. The toolkit does address it in some ways, because we talk about things like unsupervised seizures and the role of using like a device to help give parents and caregivers that peace of mind, like if they can't physically be there at all times, to be with their loved one with epilepsy. So I think that's a important piece to this, that we can monitor patients even and give them some independence to know that, at some point we want people to be able to live their independent lives, but still have some ability to monitor for things like nocturnal seizures and stuff like that.
Yeah, I just wanted to echo that, around the time usually when patients are transitioning to adult care, for those patients that are able to, some are going into college, some are going into work, and like we talked about, those are huge life transitions that can definitely increase the risk for epilepsy mortality. So I do think it's important that soon after that transition that we do have those conversations.
Yeah, there is a section in the toolkit under the social determinants of health actions, and it talks about that independent living that could happen at when they're 18 typically or older, but pregnancy, puberty, divorce, losing a job, anything that can really, that's a big change and can impact their ability to manage their epilepsy. And we also point out somewhere that it's important that the caregiver, someone's watching the caregiver to make sure they're okay, because caregivers can get really tired and overwhelmed. And if they're going through life changes that are stressful, they might not be as consistent with caring for their child or, spouse. So that's something that we hope doctors will look into as well.
Okay, so we have a comment and a question. Comment is, what a great toolkit. Thank you for all of your hard work. how will you be reaching out to physicians so they can use it? So a great question and an opportunity for us to kind of plug the ways to get this out into the community. I know from the Danny Did perspective, we're going to put this on our website and include it into certain newsletters and things of that nature, social media. Cyndi, is there any other kind of marching orders or ideas that we want to put forth?
Yeah, I mean, we have that list of all our partners, and they have all agreed to promote it in different ways. So the American Academy of Neurologic Nurses had talked about creating nurse training, like a module and certification that's specific or built around this tool. There's the American Academy of Neurology is going to be sending emails and announcing it. AES is going to put it on their website and include it as a topic. Obviously, we're here at PAME. I know that even some industry partners are going to hand deliver some of these handouts and promote it with the clinicians they work with. New York State, it's a new law just passed that there has to be disclosure. They are making it part of the resources that go with enforcing that law. So there's a lot of ways, but the more people who share it, the better. And I think I saw a question on this, is what the clinician feedback has been. Obviously, clinicians were engaged in helping build this, but we also sent it out to get feedback from some neurologists that don't always work with epilepsy. So maybe they have a few patients, and their feedback was like, oh my God, this has changed the way I'm going to handle this. Watching these videos was so empowering. This is an incredibly useful tool. So the feedback so far from clinicians has been really, really positive, and we know we're asking them to do a lot. But we really think if you keep it as simple as assessing, acting, and empowering, it really is, it's doable. I don't know, Dan and Shawna, I hope you think so too.
I agree.
Yes, definitely.
Okay. I know Dr. Freedman had talked about how we started with, I think, 96 risk factors that were discussed and narrowed it down to about 9. Question came in, why is the frequent use of emergency services listed as a risk? Doesn't that mean the patient is getting care and being responsive? So specific to that particular risk being included.
Yeah, so it's a really good point. And the reason it came up is, well, kind of 2 different reasons. One is so let's say that frequent emergency use was for breakthrough seizures, then that tells us that we need to do better in terms of seizure control, right? So we need medication or specialized diets or surgery or whatever evaluation should take place to help that patient. That's something the clinician should be thinking about. And then the other piece of that is also, let's say that those hospitalizations are not for seizures, they're for having an infection, having respiratory issues, having mental health issues. Those are still all major comorbidities that could impact epilepsy mortality, even though they're not directly related to epilepsy. And so we wanted to just have a really broad assessment of basically how often is a patient being taken to the ER or assessed by EMS, and what can we do to help that, basically.
Okay. All right, thank you. Okay, we touched on this, I think, just briefly, but maybe we can flesh out what's available in this regard. And the question is, where can a caregiver under duress turn for help? And I know Cyndi had highlighted this as an important aspect of managing epilepsy. Any thoughts or comments on those types of resources?
I feel like, in my experience, patient advocacy organizations have been really the best resource for families. I know the Epilepsy Foundation offers respite care sometimes, and so that could just be for a few hours for a caregiver to get a break. And I'm sure there are other organizations that are not coming to my mind right now, but yeah, just the idea that there are organizations out there that are looking to help with great volunteers available. And I think the biggest thing is, families being aware of those and knowing that those resources exist. So we try to connect patients as much as possible to CNF, EF, all these different organizations out there that are there to support our families.
And I think also, asking having these conversations, letting your clinician know that you are in duress and you need help is important. And, they might have a social worker who can help you with some of these issues. And, obviously we don't want anyone to be feeling that they're in duress. So it's important to talk to someone about it and ask for help, because there are people out there that can help. And yeah, going to advocacy organizations, your clinician, even community services can help with them.
And there was a comment that came through. Oh, I'm sorry. Go ahead.
Sorry. I was just going to add, of course, you have to take care of yourself as the caregiver in order to be able to give effective care to the person it is that you're caring for. So you can't ignore how you're feeling as the caregiver. That's so important.
Yeah. And to that end, if there are different caregiver support groups, some of them online, some of them in person. I know the Epilepsy Foundation recently started a sibling support group for siblings who have lost a loved one to epilepsy. So just looking in that peer-to-peer, kind of the appropriate age group for you, and oftentimes an advocacy group will be able to help point you towards some of those kinds of resources. Okay, we're getting towards the end here, so I think we'll just do one more question to kind of wrap this up, and this one might be a good way to kind of reemphasize the real value of this toolkit. So the comment is, my doctor never told us about these risks, and it caused us to wonder why. And so I think, to me, that speaks to this opportunity for relationship building and honesty and trust. Those are kind of our big pitches to physicians in terms of sharing this information. Any comments around that and what this toolkit can do to make it easier to have these conversations?
Yeah, so I think, some of the audience that we're reaching to, like you mentioned, are general neurologists and really truly may not know a lot about epilepsy mortality risk. So, increasing kind of that baseline education is so important in the community. And then for those clinicians who do specialize in epilepsy, I think the real benefit is just being comfortable with initiating these conversations. Really, anyone at any stage of training or their career can benefit from that.
And I just add, like, one of the videos, because I've heard people say, my doctor didn't talk to me about the risk of mortality, so therefore I'm not at risk. And we've tried to reinforce to clinicians, like, people want to hear from you. They want to have the conversation with you to understand their specific risk factors. And one of the videos we have talks about how my doctor didn't say anything, so I was going online, and it was really scary because, you see the worst of the worst when you go out online, and sometimes the information is not accurate. So, obviously going to, sites that we know are accurate and helpful, like some of the organizations that have helped with this, like Danny did, and CNF, EF, AES, although that's more for clinicians, but it is an issue. And I think one of the points of this tool is to let clinicians know it doesn't have to be that hard. It doesn't have to be scary.
I think the thing that doctors really don't like is when patients find stuff out through Google instead of through them. And so I think that's another selling point of this, is that this is a way for doctors to have this conversation. We model how to have this conversation. I think those videos are super helpful for doctors that are unsure of how to have this conversation. And so they can see and learn from it and then bring that knowledge to their patients, which is really, really just incredibly empowering, I think.
Great. Okay. So I think we'll need to hold it there with the questions. And if we didn't get a chance to answer yours, please feel free to reach out to us through either the PAME website or preventingepilepsydeaths.org. We want to make a promo here for the next PAME webinar, which is at the end of next month, with Dr. Davinsky and a dad, named Lou Broussard in Ohio, which I'm really looking forward to. So please save the date and plan to join us then. And then finally, we just encourage everyone, if you haven't followed PAME on Facebook, it's a great place to stay current on what we're doing in terms of webinars, planning for our upcoming December meeting, which will be in Orlando, and just staying current on different topics that are important to us as a community. So I want to thank everybody again for joining, especially our speakers. Thank you to AES for hosting, and Anne and all the work that she does. And let's redo this again in late April, and we'll leave it there for now. So have a great afternoon.
Thank you.
Thank you. Right.
Thank you.